Welcome to the module on pediatric malignancies and supportive care. I am Dr. Jennifer Young. I'm the clinical pharmacy specialist for pediatric oncology at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. This presentation is part of the ASHP/ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. This activity is designed to be interactive with questions posed to you at several points throughout. I will pause to allow you time to consider how you would answer each question. You may wish to write down your answer and the correct answer response in your handout. The disclosures are displayed on this slide. Here I have our learning objectives for this presentation. I'll take a moment here to recognize that I know that the majority of those in the audience for this course may not be actively practicing pediatric oncology in their day-to-day roles, and that's okay. Pediatric oncology may be an area that many of you would call an area of discomfort or a weak area due to a lack of experience or exposure. And I just want to take a moment to recognize that and say that that is what my job is today, to level the playing field. I've put this presentation together to highlight what I think are some of the most testable concepts in pediatric oncology, and I'll highlight that where I can throughout. Please remember, though, that there are additional topics included in the chapter handout that are not included in this presentation. Please do refer to and review the chapter as well while preparing for the BCOP exam. These are the topics that I will touch on during this presentation. A few common disease states in pediatric oncology, including acute lymphoblastic leukemia, medulloblastoma, neuroblastoma, Burkitt lymphoma, and Wilms tumor, and then a few additional topics to highlight some specific pediatric considerations, including survivorship, some supportive care topics, and ethics. But again, a reminder that there are other topics included in the handout that are not in this presentation, so please refer to that as well for a complete review. We will start off with acute lymphoblastic leukemia, or ALL. Leukemias are the most common type of cancer in children, and acute lymphoblastic leukemia is the most common leukemia subtype in children. So we'll start off with a patient case. RJ is a 3-year-old boy experiencing vomiting, fatigue, headache, and poor oral intake. On the morning of presentation, RJ has an episode of blood-tinged emesis and coughed up a large clot, which prompted his parents to bring him to the local emergency department. In the ED, his labs revealed a hemoglobin of 5.4, platelets of 21,000, a total white blood count of 20,000, with 72% circulating blasts. After a full evaluation and workup, the patient is diagnosed with B-cell acute lymphoblastic leukemia. What chemotherapy regimen should RJ receive as part of his induction therapy? Is it A, dexamethasone, vincristine, and pegaspargase, B, prednisone, vincristine, pegaspargase, and daunorubicin, C, doxorubicin, vincristine, and pegaspargase, or D, dexamethasone, vincristine, pegaspargase, and doxorubicin? And the correct answer here is A, dexamethasone, vincristine, and pegaspargase. We'll go through the details in the coming slides, but the critical determination you need to make in order to answer this question is to define if the patient is high risk or standard risk. Based on the patient's age and presenting white blood cell count, he is considered standard risk, which means a 3-drug induction regimen rather than a 4-drug induction regimen. C is incorrect because anthracyclines would be reserved as the fourth drug added for high-risk patients. There are several patient characteristics that go into a complex risk stratification approach for pediatric acute lymphoblastic leukemia. But at the actual time of diagnosis, initial risk stratification is actually very simple for B-cell ALL. The criteria put forth by the NCI, or the National Cancer Institute, is on this slide and only takes into account two patient characteristics: the patient's age and presenting white blood cell count. You can see for age, patients older than 1 year and younger than 10 years of age fall in the standard risk group. Younger patients would be separately classified as having infant leukemia, which carries a poor prognosis and has unique intensified protocols which are outside the scope of this review. Patients 10 years of age and older would by default fall into the high-risk group, as well as any patient presenting with a white blood cell count of greater than 50,000. Now here we have some additional biologic features that help to further refine pediatric ALL prognosis beyond that rudimentary NCI day one approach, utilizing age and white blood cell count. Immunophenotyping is very important. Patients with B-cell leukemia will generally have a more favorable prognosis, while T-cell patients have a less favorable prognosis. Hyperdiploid patients with greater than 50 chromosomes or double trisomies at chromosome 4 or 10 are favorable findings. And hypodiploid patients with less than 44 chromosomes have a poor prognosis. Some pertinent genetic findings are noted as well. Notably, for those unfavorable genetic findings listed, only BCR-ABL, or translocation 922, has targeted therapy that would be standardly added. Imatinib, dasatinib, and nilotinib have the most data to support use in the pediatric population. Here I have a typical example of a more detailed risk stratification approach that includes that initial presenting data of patient age and white blood count, genetics as we discussed, and a couple more key features. I will note that the approach to risk stratification will differ by the research group or the protocol, but I'll highlight a few key points that are consensus. One of which is the status of a patient's central nervous system. We know the CNS and the testes are considered sanctuary sites for leukemia, which means these are areas where disease may be more difficult to eradicate due to protective anatomical features such as the blood-brain barrier. As such, presence of leukemia in the CNS or testes will cause a patient to be up-stratified to high-risk disease. Another key prognostic factor is a patient's response to initial therapy. You can see a patient's response, defined by minimal residual disease, or MRD, on day 8 of induction and at the end of induction are very meaningful. A swift response with no detectable MRD on day 8 or at the end of induction has the potential to classify a patient as a low risk going forward. Any residual disease, defined as greater than 0.01% MRD at the end of induction, classifies a patient as high risk, and any overt induction failure is very high risk. Now, moving beyond prognostic factors to the treatment approach. I wanted to start with a high-level view of the treatment phases. As I mentioned, each patient starts with about a month of induction therapy. This is intense initial treatment with the goal of inducing a morphologic remission. Approximately 90 to 95% of patients will achieve first remission at the end of induction. Then following induction is a broad consolidation phase, the specifics of which will be very dependent on the patient's risk level, the treatment group, and the protocol being used. Because of the diversity here, I don't think the consolidation phase of leukemia therapy will be asked about on the BCOP exam. So as a quick summary, the intention of the consolidation phase is to introduce new drugs with unique mechanisms of action to achieve a more durable remission. Consolidation is often broken up into smaller phases, which may be called consolidation, interim maintenance, and delayed intensification, with some phases repeating or recurring. And then after that broad consolidation phase is maintenance. Maintenance is a prolonged phase which will span a total of 2 years from the start of interim maintenance therapy. The overarching goal of maintenance is to prevent relapse. Going forward, we'll delve a bit deeper into the induction therapy and review some pearls related to maintenance therapy, as these are the 2 phases of ALL therapy that I would consider to be more testable on the BCOP exam. ALL induction therapy can be separated into 2 big buckets: 3-drug induction and 4-drug induction. I think it's important for you to know which patients would qualify for each and what drug combinations we would be using. So 3-drug induction is reserved for patients defined as standard risk upfront. The 3 drugs will be a corticosteroid, vincristine, and pegaspargase. 4-drug induction is then utilized for high-risk patients, and here we use the same 3-drug backbone, but with the addition of an anthracycline, most commonly daunorubicin, as an intensification approach for high-risk patients. Now, in terms of the corticosteroid, you can see the choice of drug is a bit dependent on the patient's age. For our younger patients, our younger high-risk patients, defined as less than 10 years of age, they will preferentially get dexamethasone. Older high-risk patients, 10 years of age or older, will receive prednisone. By default, all standard risk patients will get dexamethasone, which actually follows the age designation for high-risk patients as well. Because remember, one of the prerequisites for a patient to be defined as standard risk is having their age between 1 year and 10 years. But let's talk a little bit more about the background on the steroid choice. I had mentioned earlier that the central nervous system is a potential sanctuary site in leukemia, so CNS penetration of the agents we choose to use in treatment is critically important. When we compare the CNS penetration of dexamethasone and prednisone, we find that dexamethasone has increased CNS penetration. This has been proven to correlate with survival outcomes as well. Patients on dexamethasone as the corticosteroid during induction therapy have shown increased event-free survival, which is specifically derived from decreased CNS relapse as compared to patients receiving prednisone during induction. So dexamethasone has a kinetic advantage that correlates with improved survival numbers, making dexamethasone the preferred agent in terms of efficacy. However, when we look beyond efficacy to the toxicity difference between dexamethasone and prednisone, we see that not all patients tolerate dexamethasone equally, which is where our age cutoff comes from. Studies have shown that children 10 years of age and older have significantly increased dexamethasone toxicity, specifically infection during induction and osteonecrosis. This is because older patients have slower dexamethasone clearance, therefore increased exposure and increased toxicity. So due to these toxicity differences, we now have to be thoughtful about who we select dexamethasone for, as we do want as many patients as possible to experience that efficacy benefit. So the classic approach is any patient younger than 10 years of age will receive dexamethasone, as these patients will tolerate it well and benefit from the increased CNS penetration. Any patient older than 10 years will classically receive prednisone. Then I'll touch briefly on CNS-directed therapy during ALL induction. Prior to the administration of any systemic chemotherapy, a diagnostic LP will be obtained to determine a patient's CNS status. Concurrently, a dose of intrathecal cytarabine will be given. Cytarabine is the drug of choice for diagnostic LPs in leukemia, as it has activity against both ALL and AML, or acute myeloid leukemia. Beyond that diagnostic LP, the frequency of intrathecal chemotherapy administration will be dependent upon the patient's CNS status. Patients that are CNS negative at diagnosis will still receive some intermittent intrathecal chemotherapy, but patients with detectable CNS disease at diagnosis, termed CNS2 or CNS3, will receive increased frequency of intrathecal therapy upfront to facilitate clearance of disease from the CNS. This is a relatively recent change for patients with CNS2 disease at diagnosis. Previously, these patients did not receive any additional therapy and were found to have increased rates of CNS relapse as a result. Now, these patients receive twice weekly intrathecal therapy until their CSF has cleared of blasts. Now, another avenue for CNS-directed therapy is cranial irradiation. While effective, cranial irradiation is toxic, especially when you consider the younger pediatric population here and the numerous long-term adverse effects cranial irradiation may cause. Because its use is very nuanced, I do not think this is an area that will be addressed on the BCOP exam. Its use is reserved as salvage for patients with CNS relapse and upfront only for a select population of high-risk patients. Modern treatment approaches have largely replaced cranial radiation with intrathecal chemotherapy and systemic chemotherapy approaches centered around good CNS penetration. So back to our patient case. We have the same patient, RJ, who has done well with treatment and is now receiving maintenance therapy. During maintenance therapy, RJ will receive weekly oral methotrexate and daily oral mercaptopurine with intermittent doses of vincristine and corticosteroids. TPMT and NUD-T15 genotyping have been completed, which indicate that RJ is homozygous wild type for both enzymes. RJ presents to the clinic for a scheduled follow-up and is found to have an absolute neutrophil count of 200. Based on this information, which of the following is the most appropriate recommendation for RJ's therapy? Is it A, resend TPMT genotyping, B, hold both mercaptopurine and methotrexate, C, omit dexamethasone from this cycle only, or D, no change to therapy, recheck a CBC at his next visit? And the correct answer here is B, hold both mercaptopurine and methotrexate. Now for A, there's no utility in retesting either TPMT or NUD-T15, given that this patient's genotype is already known. It's not going to change. If you did have a patient with significant neutropenia and they do not have either TPMT or NUD-T15 genotyping completed, it may be a good opportunity to send that, and we'll discuss why in the coming slides. Neutropenia would not be an indication to hold the corticosteroid or the vincristine, but it is criteria for a short hold of mercaptopurine and methotrexate. Once the ANC normalizes, these may be restarted at reduced dosing. So let's just briefly review ALL maintenance a bit more. As I mentioned before, the duration here is about 2 years, and this phase is required to maintain remission. The agents used in maintenance are quite simple and much less intense than what the patient has seen in the previous phases of therapy, which allows maintenance to be completed primarily in the outpatient setting. The standard backbone is oral mercaptopurine, which is given daily, a weekly dose of oral methotrexate, and intermittent pulses of vincristine and a corticosteroid. So with oral chemotherapy being the focus of the maintenance phase, patient administration and compliance become focal components for a successful maintenance phase. And with some recent data and updates regarding mercaptopurine, compliance has actually become a lot easier. Historically, there was a strong recommendation that mercaptopurine needed to be given in the evening on an empty stomach 1 hour before or 2 hours after eating and spaced adequately from dairy products. These are some stipulations that could make administration relatively challenging for, say, a 2-year-old pediatric patient. But more recent data suggest that evening administration and empty stomach administration may not have been as critically important as we thought, but rather they are able to show that as long as patients could take the medication consistently at the same time of day and consistently with or without food, the absorption was actually just as good and much easier on families. Now, the main factor that drives dosing adjustments regarding the oral mercaptopurine and the oral methotrexate is the myelosuppression that these agents can cause. We will essentially titrate the dosing of both agents in each individual patient to maintain a sweet spot absolute neutrophil count between 500 and 1500. When the ANC drops below 500, both agents are held, the ANC is allowed to recover, and then they are restarted at decreased dosing. For patients with ANCs trending above 1500, dosing will be titrated up accordingly. Most patients require multiple dosing titrations throughout the long maintenance phase. Now let's talk a little bit about the TPMT enzyme that I had mentioned in the patient case, which is short for thiopurine S-methyltransferase. TPMT is an enzyme that functions to catabolize both mercaptopurine and thioguanine. There is therefore an inverse relationship between the activity of this enzyme and the concentration of active metabolites called thioguanine nucleotide or TGN metabolites. This is an area where genetic polymorphisms in this enzyme will be very clinically meaningful. Patients that are homozygous deficient in TPMT will have minimal or no enzyme function. If treated with standard thiopurine doses, these patients would be at very high risk of severe or even fatal myelosuppression. For this reason, there is a clinical justification for testing a patient's TPMT activity prior to initiation of mercaptopurine or thioguanine. There is a higher incidence of genetic polymorphisms in Caucasian and African American populations in contrast to Asian populations, which some institutions may use to guide their practice in who they choose to test. Here we have management recommendations for patients that do have TPMT polymorphisms. The first row is homozygous wild-type patients, which reflects normal activity of the enzyme and represents the majority of the population at about 90% of patients. These patients would require no initial dose reduction and would be initiated at the normal starting dose. And then next, we have heterozygous patients. This equates to intermediate activity of the enzyme and represents about 10% of patients. Guidelines would recommend a moderate initial dose reduction for these patients, with patients starting at 30 to 80% of full dosing. And then lastly, we have the homozygous deficient patients. These patients have low or absent TPMT activity, and these are the patients with a high clinical concern for excess toxicity if dosing is not appropriately adjusted. Thankfully, this occurrence is rare and represents only 0.3% of the population, or 1 in 400 patients. These patients require a significantly decreased dose at initiation. They should receive only 10% of the full dose and dosing only 3 times per week rather than weekly dosing. NUD-T15 is a second enzyme working on the same pathway as TPMT that also has clinically meaningful genetic polymorphisms that also require empiric dose reductions. NUD-T15 polymorphisms are more common in those of Asian and Hispanic descent, which is unique as compared to TPMT. We also do have guideline recommendations for adjusted dosing based on NED-T15 activity. The notable difference here I will highlight is for homozygous deficient patients. They do separate out specific recommendations for 6-mercaptopurine versus 6-thioguanine, and this does utilize daily dosing for both as compared to TPMT homozygous deficient patients that receive dosing reduced to 10% and given only 3 days per week. The important thing here is that when both TPMT and NED-T15 results are available, they need to be used in conjunction together. If a patient is a normal metabolizer for one enzyme and a poor or intermediate metabolizer for the second, it's important that dosing follows that of the less active enzyme. Patients that have altered activity in both enzymes may require further dose reduction as compared to a patient that is an intermediate metabolizer for only one enzyme. For those of you that utilize these agents and do routinely utilize TPMT and/or NED-T15 testing, I encourage you to familiarize yourselves with the CPIC guidelines, which is the Clinical Pharmacogenetics Implementation Consortium, if you haven't already, which are cited on this slide. And now to round out pediatric ALL, I'll touch briefly on relapsed ALL. Approximately 15 to 20% of children with ALL will experience a relapse. Relapsed patients will receive reinduction therapy, which may follow a handful of pathways depending on the specifics for each patient. If it is a late bone marrow relapse, you may choose to repeat the original therapy, which the patient showed a good response to upfront. You may utilize a clinical trial in this setting, or choose a chemotherapy regimen with novel agents the patient's leukemia has not yet been exposed to. And a third option is tisagenlecleucel, or CAR-T therapy. I will not review CAR-T therapy in depth here, aside from noting that it does have an FDA-approved indication for relapsed or refractory ALL in patients up to 25 years of age. And as mentioned earlier, this is where cranial radiation may be used for patients with a CNS relapse. And lastly, there is the option of allogeneic transplant. For patients with a primary induction failure, transplant may be considered in CR1 once that is obtained. For patients with relapse disease, you may consider transplant in CR2 if the patient has B-cell ALL with an early bone marrow relapse, in T-cell patients with bone marrow relapse, or any ALL patient in third or greater relapse that is considered to be a good candidate. Now we'll switch gears a bit and discuss medulloblastoma. Medulloblastoma is a central nervous system tumor and is the most common malignant brain tumor of childhood. These tumors are located in the posterior fossa and tend to be highly invasive and rapidly growing tumors. We'll start with a patient case. PJ is a 2-year-old boy with newly diagnosed medulloblastoma. Surgical resection is performed, which reveals classical pathology. Post-resection, there is minimal residual tumor, less than 1.5 centimeters squared, and he has no evidence of metastatic disease. As the pharmacist, you are counseling PJ's parents about his planned course of multi-agent chemotherapy with cyclophosphamide, etoposide, cisplatin, vincristine, and high-dose methotrexate. PJ's parents have read that radiation is effective in the treatment of medulloblastoma and ask why this is not a planned component of treatment for PJ. Which of the following is the most accurate response to PJ's parents? Is it A, radiation is reserved for anaplastic histology, B, radiation is reserved for relapsed medulloblastoma, C, no benefit to radiation following complete surgical resection, or D, the risk of long-term neurocognitive toxicity? And the correct answer here is D, risk of long-term neurocognitive toxicity. PJ will not receive radiation therapy due to his age being younger than 3 years. He is considered high risk because of his age, despite having otherwise favorable risk factors, those being less than 1.5 centimeters squared of residual tumor, non-anaplastic histology, and no metastatic disease. Patients younger than 3 years of age are not candidates for radiation therapy due to excess long-term toxicities, and thus are classified as high risk due to the omission of radiation therapy. Now again here, I'd like to start with the risk stratification approach for medulloblastoma. And you can see, similar to ALL, that age does play a major role. There are really 4 main criteria used to stratify medulloblastoma patients. And in order for a patient to qualify as average risk, they must meet average risk criteria for all 4 components. Age here actually works in the opposite direction of what we saw in ALL. Being older will actually put a patient in the better risk group. Those 3 years of age and older can be average risk. Patients less than 3 years of age are automatically treated as high risk due to the required omission of upfront CNS radiation. Radiation therapy may cause devastating neurocognitive outcomes in this younger age group. Surgical resection follows logic, with a smaller residual tumor being more beneficial. And the third characteristic then is extent of disease. Non-metastatic disease, or M0, is defined as no evidence of tumor seeding, being subarachnoid or hematogenous metastases. And CSF histology may be negative for tumor cells. Metastatic disease, termed M1 to 4, is automatically classified as high risk. And lastly is pathology, with anaplastic histology defining a patient as high risk. Treatment for medulloblastoma is multimodal and will optimally include surgery, radiation, and chemotherapy. Surgery with a complete or near complete surgical resection is critical. Radiation is very effective in medulloblastoma patients determined to be appropriate candidates for radiation, as the tumor is very radiosensitive. However, as mentioned on the last slide, radiation will be avoided in patients younger than 3 years of age due to neurocognitive consequences in these younger patients. And then we have chemotherapy. All patients will receive chemotherapy. It is utilized in infants and young children to delay the start of radiation and used concomitantly with radiation in older average risk patients to decrease the required dose of radiation therapy. Now, what I want to emphasize here is the global approach to radiation therapy, as I think this is a simple and testable concept for the BCOP exam. First, for average risk patients, which is a reminder must be 3 years of age or older, these patients will receive multimodal therapy with surgery, reduced dose radiation therapy, and chemotherapy. Then for high-risk patients, the approach is dependent upon the patient's age. If a patient is 3 years of age or older, but high risk due to another feature of their disease, which may be a subtotal resection, metastatic disease, or anaplastic histology, these patients will receive surgery, standard dose radiation therapy, and chemotherapy. These patients are not candidates for reduced dose radiation therapy because they are high risk. And then high risk patients that are younger than 3 years of age, here we want to avoid radiation therapy due to those long-term neurocognitive effects related to radiation therapy in young patients. So next, let's talk about the actual chemotherapy these patients may receive. Average risk patients will receive vincristine concurrently with radiation therapy, followed by either cisplatin, vincristine, and cyclophosphamide for a total of 8 cycles, or cisplatin, lomustine, and vincristine for 8 cycles. Neither is proven to be superior to the other. High-risk patients that are older than 3 years will also receive vincristine concurrent with their radiation therapy, and then vincristine, lomustine, and prednisone for 8 cycles. High-risk patients that are younger than 3 years of age will receive very intensive multi-agent chemotherapy that may include myeloablative chemotherapy with an autologous hematopoietic stem cell transplant. Again, this intensified approach is an attempt to delay or avoid the use of cranial radiation due to adverse neurocognitive outcomes in this age group. And now we'll wrap up medulloblastoma with prognosis. Taken together, these patients have a roughly 60 to 80% survival with multimodal therapy. Average risk patients are closer to the 80% mark, while high-risk patients younger than 3 years of age, those that are omitting radiation, are closer to that 60% mark. Unfortunately, disease and treatment-related morbidity may be significant with treatment approaches for medulloblastoma. And next, we will discuss neuroblastoma. Neuroblastoma is a complex and diverse disease state, and honestly, one of my personal favorites. When I have learners with me that have not yet encountered neuroblastoma before, they often think just from the name that it is a brain tumor. And that's actually not the case, and I don't want any of you to fall into the same misconception. Neuroblastoma is a solid tumor arising from neural crest cells, which presents as tumors along the sympathetic nerve chains, most commonly involving the adrenal gland. And it is the most common extracranial solid tumor of childhood. Patients will often present with diffuse metastatic disease. And neuroblastoma currently accounts for 7% of pediatric malignancies, yet 15% of pediatric oncology deaths in children younger than 15 years of age. And I point this out because neuroblastoma can be very aggressive disease with a disproportionate death rate. This, unfortunately, is an area that we still have a lot of work to do to mimic those strong survival numbers that we saw in pediatric ALL. Neuroblastoma staging generally falls into 4 categories: L1, L2, M, and MS. L1, L2, and M follow a typical staging approach, L1 being a localized tumor, L2 is local regional with 1 or more image-defined risk factors, and M includes distant metastatic disease. MS is what is a little unique within our neuroblastoma and why I bring up staging. In order to have MS disease, patients must be 18 months or younger and have metastatic disease, but only to specific sites, those being the skin, liver, and/or bone marrow. Any disease to locations outside of that or age greater than 18 months will preclude a patient from qualifying for MS disease. Then risk stratification follows a similar approach. Low-risk patients will have a localized tumor and may be cured with surgery alone. Intermediate risk patients will receive multimodal treatment, chemotherapy with surgery and/or radiation if they are good candidates, and then high-risk patients received intensified therapy, which then includes immunotherapy, which we will discuss further. And then last, and what I really want to highlight here, are MS patients. These are extraordinarily unique patients within the pediatric oncology world. Again, these are young patients with metastatic disease, though isolated to specific locations. And the recommended treatment for these patients is actually no treatment at all. The recommendation is to observe. Patients that meet this very stringent criteria actually have very high rates of spontaneous regression, which require zero treatment at all. Going forward, I'm going to focus my review of neuroblastoma on high-risk patients, as this is really what I think is the most testable component of neuroblastoma for the BCOP exam. So therapy for high-risk neuroblastoma consists of 3 phases. First is induction, which includes dose-intense chemotherapy and local control with either surgery or radiation. Following induction is consolidation. This consists of tandem autologous stem cell transplants following high-dose chemotherapy. And then after consolidation is maintenance therapy. This phase is unique for neuroblastoma. The focus of maintenance here is immunotherapy with an anti-GD2 monoclonal antibody. So we haven't really walked through many studies so far in this presentation, and don't worry, there are plenty in the handout for you to review. But I did want to include one here regarding immunotherapy for neuroblastoma, because this is part of a recent revolution in standard practice for high-risk neuroblastoma maintenance immunotherapy, and a nice introduction to what maintenance immunotherapy looks like. So it's a slightly older study which compared isotretinoin maintenance therapy, which was the standard of care at the time, to a regimen which added dinutuximab, GM-CSF, and interleukin-2 to that isotretinoin backbone. This arm alternated GM-CSF and IL-2 every other cycle in addition to dinutuximab. They found statistically significantly improved event-free survival and overall survival with the addition of dinutuximab, GM-CSF, and IL-2. And while effective, this treatment was also associated with pretty significant toxicities. The common toxicities related to the immunotherapy included pain, hypotension, capillary leak syndrome, and hypersensitivity. When the study group compared the GM-CSF cycles, numbers 1, 3, and 5, to the IL-2 cycles, numbers 2 and 4, they found increased capillary leak and increased hypersensitivity during the IL-2 cycles. Taken together, the addition of dinutuximab, GM-CSF, and IL-2 to the isotretinoin backbone became the standard of care in high-risk neuroblastoma. Although with the addition of several agents at once, it was hard to determine if all agents were necessary for the efficacy benefit that was seen. So more recently, there have been a few follow-up studies on this, which specifically sought to isolate the specific impact of IL-2 on both efficacy and toxicity. These studies utilized simplified designs and compared dinutuximab alone to dinutuximab plus IL-2. All three studies found consistent results. Patients taking IL-2 had increased rates of toxicity, which was also in line with the findings of the previous study, specifically fever, pain, hypersensitivity, and capillary leak. And additionally, these new studies found no differences in event-free survival, overall survival, or response rates. Taken together, it showed that IL-2 contributed to toxicity in these patients, but did not provide a survival benefit. As a result, the Cytopen group eliminated IL-2 from standard post-consolidation therapy for high-risk neuroblastoma patients. The COG, or Children's Oncology group, followed suit and also removed IL-2. The current standard is now dinutuximab with GM-CSF for all cycles. So now for a patient case. MB is a 2-year-old male with stage 4 neuroblastoma with metastatic disease, MYC-N amplification, unfavorable histology, and diploidy. He presents to clinic today to begin cycle 1 of maintenance therapy with dinutuximab and GM-CSF. What is the role of GM-CSF in this setting? Is it A, to shorten the duration of neutropenia, B, to potentiate antibody-dependent cell-mediated cytotoxicity, C, to decrease the risk of dinutuximab-related infusion reactions, or D, an adjunct for pain management? And the correct answer here is B, to potentiate antibody-dependent cell-mediated cytotoxicity. GM-CSF stimulates the production of monocytes, macrophages, and granulocytes. These effector cells help to mediate antibody-dependent cell-mediated cytotoxicity. The Fc fragment of the dinutuximab monoclonal antibody binds the Fc receptors on these effector cells, which in turn engulf the bound tumor cell and destroy it. Now, I briefly want to review dinutuximab, as this is likely a new agent for those of you that do not practice in pediatric oncology. Dinutuximab is an anti-GD2 monoclonal antibody. GD2 is a surface glycolipid, which is expressed on 100% of neuroblastoma cells, which makes it a great target for therapy. The downside, however, of GD2 is that it is also expressed on a few healthy tissues in the body, notably melanocytes, neurons, and peripheral sensory nerve fibers. These are specifically responsible for some of the unique toxicities associated with dinutuximab therapy that we will discuss on the next slide. And the last thing I want to highlight here is the unique administration approach for dinutuximab. This is given as an IV infusion over 10 to 20 hours on 4 consecutive days, each cycle for 5 total cycles. The infusion is initiated as a 10-hour infusion with the potential to prolong to 20 hours if needed due to toxicities experienced by the patient. This therapy does require significant monitoring and supportive care, so this does require an inpatient stay for therapy. The adverse effects associated with dinutuximab can be pretty severe and therefore require the pre-medications and supportive care listed. As I mentioned, the target for dinutuximab, GD2, is naturally occurring on melanocytes, neurons, and nerve fibers. This is the etiology for the pain patients experience with infusion, as well as infusion reactions involving the skin, which may manifest as rashes or hives. To mitigate this, all patients will receive preemptive pain management with opioids, commonly via a PCA, and around-the-clock administration of antihistamines. The normal saline bolus each day prior helps to decrease the risk of hypotension and capillary leak. And the scheduled acetaminophen helps with fever management. There are very nice algorithms available for management of toxicities as they arise, with the general approach revolving around holding and slowing the dinutuximab infusion to increase patient tolerance. And then we'll transition to a quick overview on Burkitt lymphoma. The biggest takeaway regarding Burkitt lymphoma is its high proliferative rate. This puts patients at very high risk for tumor lysis at diagnosis, as many patients will actually present in an active state of autolysis before chemotherapy is even given. As such, Burkitt lymphoma actually has an initial reduction phase of chemotherapy, which is designed to reduce the risk of complications related to tumor lysis. Historically, before a reduction approach was utilized for Burkitt's, the rates of complications and associated death in Burkitt patients at the initiation of chemotherapy was very high. To mitigate this, chemotherapy is initiated with a reduction course consisting of low-dose chemotherapy. The entire intention of this chemotherapy is to incrementally reduce the tumor burden so that the risk of lysis and complications with full chemotherapy dosing at the next cycle is then significantly reduced. Resburicase, in both the prophylactic and treatment intent, is very commonly used and needed in patients with Burkitt lymphoma. The backbone of Burkitt therapy includes cyclophosphamide, high-dose methotrexate, and cytarabine regimens. The total duration of therapy for Burkitt's is relatively short, about 6 months for our higher-risk patients, and early dose intensity is critical in achieving strong survival numbers. This slide and the next summarize the treatment approach to Burkitt lymphoma, which is broken down into Group A, low risk, Group B, intermediate risk, and Group C, high risk patients. Group A patients will only receive 2 cycles of chemotherapy, termed COPAD. These patients will not require a reduction course. Group B patients will receive an initial reduction course called COP reduction. This is a single low dose of cyclophosphamide, a single dose of vincristine, and steroids. Following COP reduction, patients will receive copadum for 2 cycles. This builds upon the Group A treatment via the addition of high-dose methotrexate. That's then followed by CYM times 2 cycles, which consists of cytarabine and methotrexate. Cytarabine is an agent added to Group B therapy that Group A patients would not receive. Then group C is further escalated therapy for our high-risk patients. These patients will receive the same COP reduction as group B. They will also receive copatum times 2 cycles, though here with a higher methotrexate dose than group B. And they receive high-dose cytarabine, where group B did not. These patients will also have a maintenance phase of their treatment. And now the last disease state I'll touch on is Wilms tumor. Wilms tumor is the most common renal tumor in pediatrics. Now, screening is not something I have mentioned in the previous disease states because it does not have a role in those areas. For Wilms tumor, there is a role for screening in select patient populations. Those listed on this slide are predisposing genetic syndromes with significantly increased risk of developing Wilms tumor versus the general population. Treatment for Wilms tumor has been driven forward by collaboration between 2 large cooperative groups. Surgery is a mainstay of therapy and may be performed upfront or after a few cycles of chemotherapy. There is no standard to timing, as treatment groups tend to disagree on the optimal timing for surgery. Additionally, Wilms tumor is a radiation-sensitive tumor, so radiation also has a role in patients with higher stage disease. Now, for a patient case, SC is a 3-year-old male who presents to his pediatrician with a mass noted by his parents during his nightly bath. The mass seems to be mobile, as it is not always in the same location in the abdomen. According to his parents, SC does not seem to have pain when the parents palpate the mass. His parents also note mild hematuria the day prior to this office visit. On physical exam, SC is noted to be mildly hypertensive, and an ultrasound reveals an encapsulated mass arising from the left kidney. SC is diagnosed with a unilateral Wilms tumor, stage 1 disease of favorable histology, with loss of heterozygosity at chromosomes 1p and 16q. He is stratified as having standard risk disease. Which characteristic classifies patient SC as having standard risk disease? Is it A, his unilateral disease, B, favorable histology, C, the loss of heterozygosity at chromosomes 1p and 16q, or D, the age of 3 years old? And the correct answer here is C, loss of heterozygosity at chromosomes 1p and 16q. This patient otherwise has favorable risk factors and would be classified as low risk. However, the presence of loss of heterozygosity at both 1p and 16q define this patient as standard risk. Loss of heterozygosity at 1p and 16q is an independent poor prognostic factor. So this table outlines the risk stratification approach for Wilms tumor. You can see the relevant data are the patient's histology, age, and tumor size at baseline. Age of less than 2 years is a favorable factor, as well as a tumor size of less than 550 grams. This includes rather complex combinations with various requirements in each group. Loss of heterozygosity is a poor prognostic finding. And here we have the treatment for each group. Our very low-risk patients will receive nephrectomy alone without further therapy. Low-risk patients receive a regimen called EE4A, which includes dactinomycin and vincristine. Standard-risk patients receive DD4A with the addition of doxorubicin and potentially local radiation. Higher risk patients receive upfront DD4A. Total therapy is then dependent upon that patient's initial response to therapy, with the potential to escalate with the addition of cyclophosphamide and etoposide if necessary. And then lastly, we have our high-risk patients. Unfortunately, this group does not have a standard approach. Various treatment options are listed on the slide, and they're each described in more detail in the handout. And to round out Wilms tumor, I do just want to re-emphasize these two regimens, EE4A and DD4A, as I think these are testable on the BCOP exam. EE4A is 2-drug therapy with dactinomycin and vincristine. DD4A is 3-drug therapy with dactinomycin, vincristine, and doxorubicin. The double Ds in dactinomycin and doxorubicin may help you to differentiate between EE4A and DD4A. And next, we'll switch gears a bit to review some survivorship points related to pediatric oncology. Recent decades have brought significant advances in the treatment of pediatric malignancies, which has resulted in major improvements in overall survival numbers for many disease states. Taken all together, the overall survival rate for all pediatric malignancies is roughly 80 to 85%. With these improving survival rates, many pediatric malignancy survivors have decades of survival post-remission, which is then the focus of survivorship care. Currently, 1 in 500 young adults in the US are actually childhood cancer survivors. 2/3 of those adult survivors may suffer long-term health conditions related to the cancer treatment that they received as a child. And just for clarity's sake, we are defining late effects as therapy-related complications or adverse effects that persist or arise after the completion of treatment for a pediatric malignancy. These long-term toxicities can affect any organ system and may result in negative effects on a patient's quality of life, morbidity, and mortality. The incidence of long-term effects is associated with treatment intensity. Now, thinking through this, you would want to consider the treatment modality, the doses utilized of both chemotherapy and radiation therapy, as well as the location of radiation, the patient's age at the time of treatment, and any concomitant therapies they received. Our overall modern approach to pediatric therapy is risk adaptive. 2 disease states that we talked about are great examples for this: pediatric acute lymphoblastic leukemia and neuroblastoma. In general, we want to reserve intensive therapy for high-risk groups and de-escalate therapy, if possible, for low-risk groups while maintaining cure rates. So think of pediatric acute lymphoblastic leukemia, a disease where we have very good survival rates. The current approach to ALL therapy is to identify which favorable risk populations may be candidates for de-escalation of therapy. And if by doing so, we are able to decrease the toxicity experienced, including long-term toxicities, while maintaining those excellent survival rates. Now compare that to high-risk neuroblastoma. As I mentioned, we do not have good overall survival rates yet for high-risk neuroblastoma, so the current approach is still attempting towards intensification of therapy to achieve those good survival numbers. So now I'd like to introduce you to the childhood cancer survival study. This was a really interesting study that compared childhood cancer survivors to siblings of those survivors to compare the incidence of chronic health conditions. Survivors included were less than 21 years of age at their initial diagnosis and at least 5 years in remission. They included more than 10,000 survivors in the study and 3,000 siblings, making this a very robust study. They found that childhood cancer survivors had a high risk of chronic health conditions, most commonly cardiovascular disorders, renal impairment, secondary malignancies, endocrinopathies, and musculoskeletal disorders. The rates of chronic health conditions were double that in survivors than the siblings, with grade 3 to 4 chronic health conditions more than 5 times the rate of the siblings. Female survivors were more likely to have a grade 3 or higher condition, and the initial malignancies with the highest risk of a chronic health condition were bone tumors, CNS tumors, and Hodgkin's lymphoma. To aid in the monitoring for these chronic health conditions and management, the Children's Oncology Group has published long-term follow-up guidelines. These are risk-based and exposure-related clinical practice guidelines. The goal is to increase the quality of life and decrease complication-related healthcare costs for pediatric cancer survivors by providing standardized and enhanced follow-up care throughout the patient's lifespan. These guidelines are very easy to use and broken down by organ system and patient risk factors. We'll walk through some examples in the coming slides. And we'll start with a patient case here. So JM is a 34-year-old female long-term survivor of Hodgkin lymphoma. She was treated at 17 years of age and received ABVD, which is doxorubicin, bleomycin, vinblastine, and dacarbazine, along with radiation to her chest. Her cumulative doxorubicin exposure was 300 milligrams per meter squared. According to the COG long-term follow-up guidelines, how often should JM have an echocardiogram? Is it A, every year, B, every 2 years, C, every 3 years, or D, every 5 years? The correct answer here is B, every 2 years. The recommendation is due to the patient's total cumulative doxorubicin isotoxic equivalent dose of greater than or equal to 250 milligrams per meter squared. She also had radiation with potential impact to the heart, and as an integral part of her long-term follow-up, the COG Survivorship guidelines recommend that she receive an echocardiogram every 2 years. So next I have 2 excerpts from the COG long-term follow-up guidelines that I think are nice examples of the material covered and how the recommendations are approached. The first here is in regards to cardiac toxicity associated with chemotherapy, here specifically anthracyclines. And the risk factors included are a patient age of less than 5 years old at the time of treatment, higher cumulative anthracycline doses, here expressed in doxorubicin equivalents, and you can see the cutoffs are dependent on the patient age at the time of treatment. Exposure to chest radiation, time since treatment, comorbidities, and smoking or drug use are other risk factors considered. And then here we have the recommended echo frequency based on the patient's exposure, including both total anthracycline and total radiation exposure. The frequency for an echo may be every 2 years or every 5 years based on those combinations shown. And the second example here is in regards to secondary AML or myelodysplasia associated with chemotherapy. Risk factors here include a history of autologous hematopoietic stem cell transplant, a higher cumulative dose or combination therapy, less than 10 years since exposure to the chemotherapy, or less than 5 years since exposure to the anthracycline or etoposide. Monitoring would include for fatigue and easy bruising or bleeding, and these patients should then receive dermatologic exams annually for up to 10 years post-exposure. Now we are going to switch gears a bit from survivorship to review some select supportive care topics. I have 1 slide on febrile neutropenia and 1 slide on chemotherapy-induced nausea vomiting. For febrile neutropenia, the general management approach is similar to that of adult patients. The definitions of fever and neutropenia are the same, and it is paramount to start an anti-pseudomonal agent within 1 hour of fever. But notably, pediatric management does lack a consensus definition of low-risk febrile neutropenia. As such, seldom are patients managed for febrile neutropenia in the outpatient setting. This stems from a handful of challenges in pediatric patients, including the ability to maintain hydration, account for insensible losses, and not least of all, the challenges with administration of oral antibiotics in children. These include drug availability as an oral liquid, palatability, the cooperation of young children with frequent administrations, presence of mucositis, and impaired GI absorption. So because of these issues, most pediatric institutions will not follow a low-risk algorithm for febrile neutropenia, but will instead keep patients admitted until they have recovery of their counts. And next is a few points on chemotherapy-induced nausea and vomiting. Unfortunately, though a common theme in the pediatric world, we have relatively limited pediatric-specific data regarding the emetogenicity of individual drugs or combination regimens. So instead, we have to rely on extrapolation of adult data. There is limited data on newer agents, specifically those combination agents in pediatric populations. Palonosetron does more recently have a niche role that has been built into the pediatric guidelines, with the promotion of preferential use of palonosetron over other 5-HT3 antagonists in patients that are not able to receive dexamethasone as a standard antiemetic. So dexamethasone may routinely be omitted from acute chemotherapy-induced nausea vomiting prophylaxis for pediatric leukemias and brain tumors due to concerns for the interference with apoptosis in steroid-sensitive tumors, the risk of fungal infection in leukemia patients, and the potential to decrease chemotherapy penetration across that blood-brain barrier due to the anti-inflammatory effects of dexamethasone. All right, now ethics and informed consent are the last topic I have here, and we'll round out this presentation. The first thing I'd like to address is the difference between assent and consent. Patients younger than 18 years of age are considered minors and may lack the capacity to make informed decisions regarding their own medical care. So some definitions to ensure we are all on the same page. Consent is a voluntary agreement. Assent is an affirmative agreement of the child, which is usually coupled with informed permission of the parent or the patient surrogate. And dissent is then equivalent to a refusal. And so here we have our last patient case. AJ is a 12-year-old female with newly relapsed rhabdomyosarcoma. The oncology team is reviewing the diagnosis and treatment options with AJ and her parents. Unfortunately, AJ's prognosis is poor and there is no standard of care. The team informs the family of an open clinical trial of a new targeted investigational agent that AJ would qualify for. This clinical trial is an excellent match for AJ based on the genetic profile of her tumor, and her team is optimistic that she may have a good response. What consent from the family would be required to enroll AJ on study? Would it be A, assent from the child and permission from both parents? B, assent from the child and permission from one parent? C, permission from both parents? Or D, permission from one parent? And the correct answer here is D, permission from one parent. Assent is not required from the child, as the treatment option in this case is thought to provide significant benefit to AJ and is only available through this research study. This therapy would be associated with greater than minimal risk to AJ, but does provide the potential for direct benefit to AJ. Therefore, this treatment option only requires consent from one parent rather than two. This slide is where I will wrap up this presentation, though I do want to take a moment to highlight this, as I do believe this is testable material on the BCOP exam. So this table outlines what we just applied to the previous patient case. The foundation for these decisions regarding whether assent from the child and/or permission from the parents is required really comes down to the perceived risk to the patient and perceived benefit to the patient. If no greater than minimal risk is assumed to the patient, then you would need assent from the child and permission from one parent, with the exception that assent from the child may not be required if the child is expected to gain significant benefit from the study and this treatment is not available outside of the study. If greater than minimal risk is expected to the patient with the prospect of direct patient benefit, then again, assent is required from the child with the same exception, and permission is required from one patient. If, however, there is greater than minimal risk to the patient without the prospect of direct benefit, then assent is required from the child without exception, and permission is required from both parents. And lastly, all other research also requires assent from the child and permission from both parents. And then, all right, that actually concludes the presentation. So thank you so much for participating. I hope you have a great day.